This is part 2 of nursing care of clients with cardiac disorders. In particular, we're talking about inflammatory cardiac disorders. We'll begin with pericarditis. Remember that the pericardium holds the heart in place and it helps it work properly. The sac is made up of 2 thin layers of tissue that enclose the heart. Between the 2 layers is a small amount of fluid. This fluid, there's just enough to keep the layers from rubbing against each other and causing friction. We do not want friction because of these membranes rubbing against each other. Since most pericarditis is caused by a virus, it will heal naturally. There's no specific curative treatment. Ordinary antibiotics do not work against viruses. Pericarditis that comes from a virus usually clears up in 2 to 3 weeks. Sometimes, I would say that it clears up between 2 weeks and 3 months. So in other words, it's a viral infection that will clear up on its own. Pericarditis, itis refers to inflammation. So it is an inflammation of the pericardium, and it may be a primary disorder or it may develop secondary to another disorder. It affects 40 to 50% of patients who have end-stage renal disease and uremia, which is the buildup of urea in the bloodstream. Heart attacks and cardiac surgery are also common causes of pericarditis. Inflammation of the pericardium may result in pericardial effusion, fibrosis, or scarring. These changes restrict cardiac function. Okay. Classic manifestations of pericarditis include chest pain, a pericardial friction rub, and fever. Dyspnea and tachycardia are also common. When the pericardium is scarred or thickened, the heart has difficulty contracting, and this is because the pericardium has shrunken or tightened around the heart, constricting the muscles' heart movement. Medication is administered according to the manifestations. Aspirin and acetaminophen are used for fever. NSAIDs are used to decrease inflammation and for comfort. And corticosteroids may be used as well in the treatment of pericarditis. A procedure called Pericardiocentesis may be indicated to remove pericardial fluid. Okay. Remember, there's only supposed to be a small quantity of fluid. If the fluid builds up, we may have to remove that fluid to allow the heart to expand and contract. Nursing diagnoses applicable to pericarditis include acute pain, ineffective breathing pattern, risk for decreased cardiac output, and activity intolerance. Okay, now we're switching a little bit topic here. The next condition we'll talk about is cardiac tamponade. Sometimes fluid collects between the heart and the pericardium. This is called pericardial effusion, and this may lead to a condition called cardiac tamponade. When the fluid accumulates, it can squeeze the heart and prevent it from filling with blood. This keeps the rest of the body from getting the necessary supply of oxygen and can cause dangerously low blood pressures. A cardiac tamponade can happen when the chest is injured during surgery, radiation therapy, or an accident, such as a motor vehicle accident. Cardiac tamponade is a serious medical emergency and must be treated immediately. Pericardiocentesis is the procedure which is used to remove the fluid from the pericardial sac. It can be used therapeutically and diagnostically. Remember, only a small amount of fluid should normally be there. So this excess fluid needs to be drained. Okay. Now, what you'll notice with your patient who is having a cardiac tamponade is that the systolic and diastolic blood pressure numbers begin to approach one another. And we call that a narrowing pulse pressure. So you'll see that the systolic and diastolic numbers become closer and closer together. And we refer to that as a narrowing pulse pressure. And you know that the patient's cardiac output is also dropping, right? So they're going to have a hard time breathing. And it's quite amazing to see once they drain this fluid, when the heart can beat efficiently again, then the patient can immediately start to breathe much better. And we also see the return of their blood pressure numbers to more normal, what it was prior to the cardiac tamponade. Now, the healthcare provider is going to insert the needle and guide it into the pericardial sac. He may have access to an echocardiogram to help him position the needle and monitor the fluid drainage. But they may not, because this can be done at the bedside as well. And so if they do not have it, for certain, the nurse would have the responsibility of monitoring the EKG machine and notifying the physician if you observe PVCs being thrown by the patient. When the physician, I say physician in general, could be male or female, inserts the needle, and they're trying to find that space where the fluid is, the tip of the needle may touch the myocardium, eliciting an irritable reaction this is a mechanical irritation that causes the heart to throw PVCs. By notifying the physician, he then can pull back on the needle so that he's not irritating the heart muscle. On this slide, we see a list of various conditions that can lead to a cardiac tamponade in our patients. So there's a whole list of things that can lead to it. There's no sense in memorizing all of these various conditions, but as we already said, viral infections that cause pericarditis can lead to a cardiac tamponade, as we've seen in this presentation. But even our patients who have had heart attacks, kidney failure, open heart surgery, yes, these patients all could develop a cardiac tamponade. So again, it comes back to monitoring our patients, because we know the complications that can occur as a result of their history or any surgery that they've undergone. Where I've seen it very commonly in the hospitals is with our patients who have end-stage cancers. They will end up getting a recurrent cardiac tamponade. And when we see this, when they are beginning to struggle for breath and they're short of breath, you need to be monitoring their blood pressures and looking at those trends to see if the systolic pressure is coming down and the diastolic's going up and they're approaching each other. So we can watch these trends that would give us an idea if a cardiac tamponade is developing. Okay, here we're going to switch and talk about our valvular heart disease. It's often a consequence of rheumatic heart disease. Remember, we studied that before. So we want to always do measures that prevent rheumatic fever. That's going to be essential in preventing a lot of valvular heart disease that we encounter. So the nurse's role again comes down to emphasizing early and effective treatment of strep throat, including the importance of completing the full prescription of antibiotics, and also prophylactic antibiotic therapy before invasive procedures is also important. Valvular heart disease interferes with blood flow to and from the heart. Acquired valvular disease may be a result of an acute condition, such as infective endocarditis, or from a chronic condition, such as rheumatic heart disease. Congenital heart defects may also affect heart valve function. And we see in this slide two major types of heart disease, valvular heart disease, stenosis and regurgitation. Remember, stenosis is when the valves don't open all the way. They become rigid so that the opening is narrow. I like to use that example of a rusty hinges on a door. When you're trying to push the door open, but the hinges are so rusty that you can't open it all the way. And that's what we see in the picture on the left. Look at the lumen, the opening is very narrowed. That's a stenotic valve. And then on the right, we see a picture of regurgitation. And sometimes that's referred to as an incompetent valve. Also, it's referred to as insufficiency. So there's three different words that can describe a valve like this when the valves do not close all the way. Okay, so now we have this large opening because the valves do not close all the way when they're supposed to. Okay, so regurgitant valves or insufficient or incompetent valves do not close all the way. Again, this affects the blood flow. There's turbulent blood flow, and the heart does not function efficiently like this. So let me make sure you understand that when you have valvular heart disease, this can result in heart failure, okay? And that leads to decreased cardiac output. Okay, so the way that we treat valvular heart disease really depends on what else is present. For example, if there is heart failure present with this valvular heart disease, the client is treated with medications like we have listed here: diuretics, ACE inhibitors, vasodilators, and possibly digoxin as a positive inotropic agent to help the heart contract stronger. Now, if the patient also has atrial fibrillation, which is an electrical conduction problem that predisposes the patient to forming clots, then they'll need to be on an anticoagulant therapy as well. Another way that we treat valvular heart disease is by giving patients prophylactic antibiotics, especially prior to any invasive procedures, including routine dental work or surgeries. Okay. Now, surgeries and invasive procedures include, for valvular heart disease, these various procedures listed here. I think we'll talk a little bit about them as we go through. Percutaneous balloon valvuloplasty is a cardiac catheterization procedure to treat stenosis in the heart valves. It's very similar to a balloon angioplasty that we've talked about before, except instead of opening a coronary artery, a valvuloplasty stretches open a narrowed heart valve. One thing I want to mention here about these percutaneous interventions, such as cardiac catheterization, and here we see a balloon valvuloplasty. When you have a large catheter and guide wire, inserted into the groin, the biggest complication after these procedures is bleeding. Okay, so when they remove the catheter, a lot of pressure has to be applied to make sure the patient doesn't bleed, because you can end up with a very, very large hematoma in the upper leg, and that can cause the patients, I've seen them have to stay in the hospital for another week following the procedure. So remember, we want to make sure that the leg is flat after they come back from these type of procedures where you've had a catheter inserted into the groin, because they have to keep it still for about 4 hours or so, whatever the protocol is at your hospital. But for a number of hours, there should be no flexing of that leg, because we want the clot to form and we want to make sure they do not bleed. Okay, so that's the number one complication of any of those percutaneous procedures going through the groin or femoral vein or artery. Okay, and moving along to the well, the valvuloplasty is kind of the same. We'll talk about that in some pictures. And let's talk about all these other, well, we have an open commiserotomy, annuloplasty, and valve replacement. Okay, remember with that, when you have that balloon valvuloplasty, the balloon is inflated to stretch the valve open. And balloon valvuloplasty is used to treat blockages of the mitral valve or of the aortic valve. Okay, and remember, the left side of the heart is the workhorse of the heart. It's the side that has the higher pressures. Everything is the higher pressure on the left side there. So those valves on the left side, including the aortic and the mitral valve, are under more stress and pressure than you may find on the right side of the heart. So here's a picture of that procedure, the percutaneous balloon valvuloplasty. Now this is just showing you what is occurring across the valve, because that is the purpose of this. But remember that catheter, that green catheter that you see in the picture here, enters the body from the groin area and is advanced all the way up, so that when the balloon is inflated, it is being inflated across the valve. Now the technique of valvuloplasty is a little different. This is aimed at making sure that the flaps or leaflets of the valves close properly, preventing blood from backing up into the atrium, okay? So in a healthy heart, you know that the blood is going to flow from the atria to the ventricles and from the ventricles to the rest of the body. But we cannot have blood backing up into the atria, going backwards. Okay, so that's what is occurring. You see that there is a suturing. It's the suturing technique that's being used here to make sure that those leaflets come together and close properly. It's all about restoring the efficiency of blood flow through the heart, and which ultimately is going to affect cardiac output. Okay. Now, I'm not expecting you to be surgeons. I just want you to have a vague idea of when your patient comes back, you'll understand what they have undergone. Okay, and here's another procedure. It's called a commiserotomy. It is a special form of valvuloplasty. It's used when the leaflets of the valve become stiff and actually fuse together at the base. Remember, the base of the valve is referred to as the annulus. That's the ring portion of the valve. It's at the base, like the foundation, and the leaflets are attached to that annulus. Sometimes a scalpel is used to cut the fused leaflets near the ring, and that helps them to open and close better. In other cases, they may use a balloon catheter, similar to a catheter used during angioplasty, and insert that into the valve. When the balloon is inflated, it splits I guess the word splits or cuts the the leaflets apart and frees the leaflets to open and close fully. Now, annuloplasty is a technique aimed at repairing the fibrous tissue at the base of the heart valve called the annulus. Sometimes the annulus becomes enlarged, which enables blood to back up into the atrium. Again, blood going in the wrong direction. To repair this, sutures are sewn around the ring to make the opening smaller. This creates a purse string effect around the base of the valve and helps the leaflets meet together again when the valve closes. Sometimes, as you see in this picture, actually, they have a synthetic annulus that they are replacing. Sometimes there's been so much destruction to the base or annular ring that we have to use a synthetic ring or annulus to repair the heart valve. So let's talk about heart valve replacement. We talked about repair and a lot of the techniques and procedures used for that. But sometimes the valves have to be replaced. And this is where you will get nursing questions. They want to make sure you understand the difference between a biological valve and a mechanical valve. Okay, so we see that valves may be repaired or replaced. Replacement heart valves are either natural, biologic, or artificial, mechanical. Natural valves are from human donors, cadavers. Modified natural valves are from animal donors, such as pigs. So when you see the word porcine, you realize porcine is referring to valves that came from animal donors or pigs. And this is which are placed in a synthetic ring. And then we have the artificial valves, which are made of metal or plastic. Now, the difference between these two, natural versus mechanical, we see that the natural valves rarely require lifelong medication to prevent blood clot formation. Okay, in other words, if you receive a human or porcine valve, natural valve, that patient will not have to have anticoagulation for the rest of their lives. But that is not the case with a mechanical valve. The mechanical valve means that that patient will need to have anticoagulant therapy for the rest of their lives. Okay, so what is the advantage of a mechanical valve? Well, it's that they last longer. So there's a trade-off of lifelong anticoagulation. In some cases, is worth it to avoid a second valve replacement surgery. Okay, so that's the big difference. It has nothing to do with rejection. There's no concern, there's no medication if you receive a biologic valve in terms of rejection. That's not a concern. It just isn't. What is the concern is that with a mechanical valve, it's basically thrombogenic, which any device, when it's inserted inside the body, is going to be thrombogenic. The body wants to form a clot there. And so for that reason, they must undergo lifelong, usually Coumadin therapy. Okay, so there's all kinds of issues that have to be taken into consideration, but those are the big ones that you need to be concerned about as a nurse. The physician will have to look at other considerations. For example, what if it's a young 25-year-old woman of childbearing age and she would like to have a child? Would it be a good idea for her to be on anticoagulant therapy? So there are lots of considerations. Age, if there's a really old patient, maybe he would do fine with anticoagulant therapy if it means that he doesn't have to undergo a second heart valve replacement surgery, because maybe they don't anticipate that he'll be in good enough health to ever have a second surgery. So there's many considerations, but you need to know about anticoagulant therapy. Oh, good. I wrote this all out for you, so I'll read it. Mechanical valves usually last 20 years or more. You're less likely to need another surgery to replace a mechanical valve in one lifetime, but they can cause blood clots, so patients will need to take Coumadin. Now, the natural or tissue valves are less likely to cause blood clots, so patients don't have to take warfarin. But tissue valves don't last as long as mechanical valves, so the patient may need another surgery to replace it. Tissue valves typically last anywhere from 10 to 18 years. You see there's quite a span of years there. We can't tell you exactly how long it's going to last. So these are all considerations for heart valve replacement.